for pharmacists working in hospitals, because a lot of dose adjustments is based on whether the patient is having acute kidney injury or chronic kidney disease. There is a difference between acute kidney injury and chronic kidney disease. Acute kidney injury most of the time is reversible, while in case of chronic kidney disease, obviously it is not. It is irreversible, and acute kidney injury is abrupt reduction in kidney functions, as evident by the changes in lab values, serum creatinine, blood urea nitrogen, and urine output. While in case of CKD, it is gradual loss of kidney function over time due to diabetes, hypertension, or any other complication. AKI is diagnosed if one of the following criteria is met, that is increase in serum creatinine of at least 0.3 milligram per deciliter within past 48 hours, or a 50% increase in baseline serum creatinine within 7 days, or a urine output of less than 0.5 ml per kg per hour for at least 6 hours. There are ways to classify acute kidney injury, rifle, AKIN, and KDIGO. RIFLE is an acronym of risk, injury, failure, loss of kidney function, and end-stage renal disease. It is the oldest classification. AKIN, as the name indicates, acute kidney injury network is a group of nephrologists and intensivists who further refined the RIFLE criteria and based AKIN classification on past 48 hours urine output and serum creatinine. The most widely used classification of acute kidney injury is KDIGO, which is Kidney Disease Improving Global Outcome. It is a global organization which works for the development and implementation of guidelines for the kidney diseases. Now, I will not just read, I will share the slides, and you can see, or if anyone wants to memorize or go in detail, they can see, since we have a short time and I have to give other speaker also time. So I will try to finish my presentation in time. The important thing in this KDIGO classification is the staging of the kidney injury. There are 3 stages, and it is based on serum creatinine and urine output. KDIGO classification not only gives widely accepted staging of AKI, but it also gives guidelines about the renal replacement therapy, and also recommends that in patients less than 18 years, decrease in eGFR less than 35 ml per minute per 1.73 meter square. Then there are the most common causes of AKI in the hospitalized patients, which we see is the sepsis or the bacterial infections with which they come, or the critical illness, circulatory shock, or cardiac surgery, or major non-cardiac surgery, or nephrotoxic drugs. About the drugs we will discuss in detail in later. And the most common cause of AKI in the hospitalized patients is the contrast-induced kidney injury. Then there are certain susceptibilities of AKI, like dehydration or volume depletion, advanced age, female gender, black race, chronic kidney diseases, diabetes mellitus, cancer, anemia. While discussing AKI, it is very important to know the pathophysiology and the categories of AKI. Like there are 3 categories: pre-renal AKI, intrinsic AKI, and post-renal AKI. In the pre-renal AKI, it is basically due to the reduced blood delivery to the kidneys, and the common causes are volume depletion, decreased effective circulatory blood volume, and the functional reason is the drug-induced ACE inhibitors, NSAIDs, angiotensin receptor blockers, cyclosporin, and tacrolimus. Prompt correction of volume depletion can restore kidney function to normal because no structural damage to kidney has occurred. In intrinsic AKI, damage is within the kidney structure, like vascular damage, glomerular damage, acute tubular necrosis, or acute interstitial nephritis. It is due to the drugs, NSAIDs, and infections. In post-renal AKI, it is due to the obstruction of urinary outflow. The obstruction can be due to the bladder outlet obstruction, due to benign prostatic hypertrophy, prostate cancer, or anticholinergic drugs. And urethral obstruction can be due to the malignancy, and pelvic and renal obstruction. Post-renal AKI accounts for less than 10% of cases of AKI. Rapid resolution of post-renal AKI without structural damage can restore kidney function. Then there is a diagram which summarizes pre-renal, post-renal, and intrinsic renal impairment. The areas where the diagram depicts the areas. The important thing is that by monitoring serum creatinine on routine basis, it can be estimated whether kidney function is improving or worsening. Kidney function not only based on the serum creatinine but also on the urine output. If the serum creatinine is high but the patient is making good urine output, then the patient is most likely the condition is most likely reversible, and there is no need of renal dose adjustments of antibiotics or any other drugs, because adjusting dose, if at this stage, if the patient is making good urine output and the patient is and the condition is going reversible, adjusting doses can cause increased sepsis burden, especially of the antibiotics. If you are adjusting the doses of antibiotics, it can increase the sepsis burden of the patient, because the doses of the antibiotic will be subtherapeutic, and the infection will not be treated properly. It can also result in antibiotic resistance. Oliguria means urine output of less than 400 ml over past 24 hours, and anuria means less than 50 ml over past 24 hours. Clinical presentation and diagnosis of AKI include peripheral edema. Obviously, the patient having acute kidney injury, not passing urine and retaining all the electrolytes, will have edema. It will have weight gain, nausea, vomiting, diarrhea, anorexia, mental status changes, which are due to the electrolyte imbalance. And fatigue is also due to electrolyte imbalance. Then shortness of breath due to edema and pruritus. There are certain tests which are commonly used for the diagnosis and for the monitoring of AKI, like elevated serum creatinine, elevated BUN, decreased creatinine clearance, BUN creatinine ratio, hyperkalemia, and metabolic acidosis. The best way to prevent AKI is that the individuals who are at high risk, their risk should be identified, and those factors should be removed to prevent AKI in them. Like if they are having falling drugs like aminoglycosides, ACE inhibitors, amphotericin B, NSAIDs, and cyclosporin, or tacrolimus, they should be evaluated for the risk versus benefit ratio, and if possible, their therapies or drugs should be substituted. The most common AKI in the hospitalized patient is contrast-induced AKI. KDIGO guidelines suggest that either isotonic sodium chloride or sodium bicarbonate solution should be given for volume expansion, and oral fluids should be used. Using alone oral fluids in patient at increased risk of contrast-induced AKI is not sufficient or not recommended. Oral and acetylcysteine. Previously, IV acetylcysteines were used, 1.2 gram acetylcysteine pre and post contrast. Now, KDIGO suggests that oral and acetylcysteine together with isotonic crystalloids in patients should be used in patients with increased risk of contrast-induced AKI. Treatment in the treatment of AKI, goal is important. The goal should be to minimize the degree of kidney injury and reduce extrarenal complication, and restoration of renal function to pre-AKI should be the ultimate goal. The treatment approach for the AKI is supportive care. Currently, there is no definitive therapy. Supportive care includes adequate nutrition, correction of electrolytes and acid-base abnormalities, fluid management, hematologic abnormalities, correction of hematologic abnormalities, medical management of infections, cardiovascular and GI conditions, and respiratory failure. All drugs should be reviewed, and dosage adjustments should be made on the basis of estimate of the patient's GFR. The non-pharmacological therapy is the maintenance of the adequate cardiac output and blood pressure to optimize tissue perfusion, and discontinue medication associated with diminished and renal blood flow. The appropriate fluid and electrolyte correction measures should be initiated, and non-pharmacological therapy includes renal replacement therapy in severe AKI, and it includes both hemodialysis and peritoneal dialysis. The absolute indication for dialysis includes severe life-threatening situation in which a patient is making either very low or no urine output with all high levels of more than higher levels of lab. For example, burn greater than 100 milligram per deciliter, potassium greater than 6 milli equivalent per liter, magnesium greater than 9.7 milligram per deciliter, and metabolic acidosis with a pH less than 7.15, and diuretic resistant fluid overload. Means you are giving furosemide, you are giving metolazone, combination of loop and thiazide diuretics is being used, but still patient is making no urine output. So in such a condition, non-pharmacological intervention is required, and patient should be given dialysis session. In pharmacologic therapy, loop diuretics are effective to reduce fluid overload, and but they can worsen AKI, so they should only be used to reduce fluid overload. Thiazide diuretics as a single agent are generally not effective, so they are usually used in combination with loop diuretics like metolazone oral, and loop diuretic furosemide is given IV as a continuous infusion or intermittent infusion. Mannitol is now not recommended for treating volume overload associated with AKI. And potassium sparing diuretics and low dose dopamine is not indicated now in treating AKI. If the patient is facing diuretic resistance, then combining two agents can help. Combining two agents can have synergistic effect, like I have told earlier, thiazide diuretics, metolazone, and in loop diuretics, furosemide, they are given in combination, and with the start of this combination, usually patient start making good urine output. But if the patient is resistant to this combination as well, then patient is given dialysis session. There are certain reasons for the resistance in patients with AKI. Diuretic resistance reasons include excessive sodium intake. So sodium from the nutritional sources and medications should be removed. Inadequate diuretic dose or inappropriate regimen. The the dose should be increased, and continuous infusion should be given, or combination therapy should be given. Reduced oral bioavailability of furosemide can also result in diuretic resistance. So in such case, IV furosemide should be given if possible. Then reduce renal blood flow due to drugs such as NSAIDs, ACE inhibitors, vasodilators can cause reduced renal blood flow. So these drugs should be discontinued if possible and substituted on other regimens. NSAID use can also cause diuretic resistance due to decreased renal blood flow. The key in the acute kidney injury is the electrolyte management. All the electrolytes should be monitored regularly. Serum electrolyte should be monitored daily. Hyperkalemia, hypernatremia, and phosphorus and magnesium, they all should be monitored and rectified as per labs and the condition of the patient. The key monitoring parameters for patients with established AKI should be fluids should be monitored in every shift. Patient weight should be monitored daily. Patient weight is very important, since if the patient gains weight, it means patient is having fluid retention or edema, or so it should be rectified. If the blood pressure, heart rate, and arterial pressure, they should be monitored by every shift. Blood chemistry should be monitored daily. Blood urea nitrogen should be monitored daily. Drugs and their dosing regimens are checked every time by pharmacists whenever they are entered, or the order is, or the patient or the doctor's prescription is renewed. They should be monitored. In the guideline, it is written daily, but uh, uh, here the role of pharmacist is important. Whenever the drugs are changed, it should be reviewed by pharmacist. Blood glucose should be monitored daily. It is the minimum requirement. Daily is the minimum requirement. If it is being monitored 4 hourly or 6 hourly, it is good. Urine analysis should also be done every time. Measured urine collection measurement should be performed, and there are not only pharmacological strategies or non-pharmacological strategies, but diet and food also have very important role in patients, in the health of patients. There are certain foods which help patients with the kidney disease. They mainly contain antioxidants like raspberries, garlic, onions, cherries, apples, red bell peppers, cabbage. And there are certain foods which should be avoided, and they also not good for maintaining healthy lifestyle, like dark colored soda, pickles, olives, canned foods, tomatoes, excessive use of tomatoes and potatoes, and processed meats. Take home message is AKI is, most of the time is reversible. The timely diagnosis and its treatment can help a patient avoid chronic kidney disease, which is very difficult to manage and very expensive to manage. Contrast induced AKI is most common cause of AKI in hospitalized patients, and so its prophylaxis should be done. Patient should be well hydrated before the procedure, before giving contrast. Hypertension treatment is not only to control and reduce blood pressure, but also to prevent organ damage. So the blood pressure should be in control and should be manageable all the time. Patients with AKI should be monitored with serum creatinine and urine output to stage the severity. Uh, Diuretics nowadays have no role in uh, the prevention of AKI, but they are only used in the management of volume overload. The patient should be managed according to the AKI, according to stage and cause. Patients with AKI should be evaluated after 3 months for the resolution, new onset, or to determine the worsening of the pre-existing AKI or CKD. These are the references. Thank you.
Thank you so much, ma'am, for the great presentation.
Thanks.
So, let me introduce our next speaker who will be covering diabetic nephropathy. Dr. Sidrah Andleeb. She's PharmD and has done American board certification in pharmacotherapy with added qualification in infectious diseases, and she's MPhil in pharmacology. She's currently working with Shoppers Drug Mart. She's currently working with Shoppers Drug Mart in Ontario, Canada. She has worked Shaukat Memorial Cancer Hospital and Research Center, Pakistan as deputy manager, pharmacy with 11 good years practice experience. She served as the residency program manager at SKM and led the department to a successful ASHP accreditation of the residency program. She has worked as a member of the Provincial Area Scrutiny Committee in Pakistan. She also served as official trainer for the pharmacist Provincial Pharmacy Council. Moreover, she is an inspiration for every Pakistani pharmacist throughout the world. Welcome on board, Dr. Sidrah. You may start the presentation.
Thank you very much, Dr. Uzair. Thank you very much, Dr. Siddiqui. Assalamu alaikum, everyone. An excellent presentation by Dr. Umme Javeria. And it's such a good lineup that we talked about the acute kidney injury. And now we're going to talk about a chronic version of kidney disease. So I will be talking about diabetic nephropathy. It is usually a chronic condition which usually develops over a period of time. And yeah, I know conflicts of interest. We're going to talk about the prevalence and the pathophysiology and the management. And the management has a lot of categories in chronic kidney disease. So the reason I'm adding the how to classify CKD is because, as I discussed earlier, that diabetic nephropathy is specifically a chronic condition. And we're targeting all the management modalities which are involved in the management of CKD. So there are two basic versions of classifications. We covered that in the BCPS lectures as well, just a revision for all of us. So KDIGO is the most common. Javeria mentioned KDIGO earlier. So this is amongst the most commonly worldwide accepted basis of guidelines for kidney diseases. And the classification basically talks about the GFR. It categorizes the kidney function on the basis of GFR, the glomerular filtration rate. So anything more than 90 is okay. It's grade 1. It's okay. It's a well-maintained, controlled kidney condition. Grade 2 is 60 to 89. Which is kind of a moderate. 3A and 3B is between 30 to 60. So it's a good thing that they've divided this up in two categories, like 30 to 45 and 45 to 60, because a lot happens in the version between 30 to 60. So any patient with say a creatinine clearance of 50 ml per minute is not equivalent to a patient who has a creatinine clearance of 35 ml per minute. So there's a difference in the dynamics of these two kinds of patients. That's why they've divided it up into 3A and 3B. It's a very critical phase, a moderate abnormality in the kidney function. Then grade 4 is 15 to 29, and any functionally anuric patient that is less than 15 mL per minute would be a grade 5, which is like an end-stage renal disease. Right, so it's important to remember all of these categories because it helps us manage our patients well. It's amongst the most common secondary abnormalities after diabetes. So when we talk about diabetes, it's not just the diabetes itself. We talk about the metabolic syndrome, which involves the hypercholesterolemia, and it talks about the cardiac diseases, the risk of MI, the risk of heart failure, and then it talks about the kidney abnormality, because high blood sugar levels have a profound effect on the functionality of the kidney, and over a period of time, it just gets worsened. So every 1 out of 3 patients of diabetes may end up developing diabetic nephropathy. It's that severe. Talking about pathophysiology, it's usually multiple factors that lead to this chronic development or chronic derangement in the kidney. So think about it, there's increased glucose level in the blood. So definitely there's going to be a glucose associated diuresis because the kidneys have to hyperfilter all the time a higher volume of dextrose in the urine. So in order for that, this hyperfunctioning of the kidney alters the glomerular filtration pressure. As a result of that, there may be vasoconstriction in the afferent arterioles. There's an increase in the pressure of the blood at the level of the kidney, which is transferred to the heart. So the risk of a cardiac hypertension because of the kidneys is a very common presentation that we usually see. Then there is oxidative stress, because all of these things and the multiple molecules that we have, they add the oxidative stress, and the oxidative stress is bad for any cell in any organ, in any organism. So because of this oxidative stress, there may be cytokine hyperproliferation, which is NF-kB is the most common one amongst them. And this proliferation may lead to inflammation within the kidney and increase in the space. So what happens in inflammation is that there is an increase in the size of the space or the interstitial spaces, and there is hyperfiltration of albumin out of the kidney. So the patient may end up losing a lot of albumin. So there will be albuminuria. So when we come to albuminuria, that's the second category of how we define CKD, which we're going to talk about in the next slides. So there is microalbuminuria, which is like excretion of albumin in the urine. And then there is macroalbuminuria, right? So initially, there may be some traces of albumin in the urine, but with the passage of time, there may be severe excretion of albumin, which may be more than 30 grams per day. And when it happens, when it's more than 30, it's usually called as a classic nephrotic syndrome. That's what we call it, right? So it's not only a decreased GFR, but coupled with that, there is an increased albumin excretion, which we are focusing when we're talking about diabetic nephropathy. So we look at both of these factors, right? So categorization of the CKD based on albuminuria, how do we do that? So it's either an A1, A2, or A3, A1 being the least severe and A3 being the most severe condition of all. So less than 30 is A1, 30 to 300 is A2, and more than 300 is severe albuminuria, which is usually associated with ESRD, end-stage renal disease, right? So just to activate our learning a bit through an exercise, just do a few questions here. So it's a 55 years old man who has a history of hypertension and a newly diagnosed type 2 diabetes. He denies alcohol use, but he does smoke cigarettes, which is 1 pack a day. His medication includes atenolol and a multivitamin. At your pharmacy, his blood pressure is 149/92. His albumin creatinine ratio is 400 mg per gram. A recent serum creatinine is 1.9, which is consistent with the value measured 3 months earlier. His eGFR is 50 mils per minute per the standard BSA. So which category does he fall in? Any comments here? Great. Yeah, Rifat, you're very right. It is. So it's 45 to 60. It is 3A. Very right. Very right. So happy to see that all of us are on the same page. And I was able to explain that well. Thank you so much for answering. Yeah. So as we know, this is 3A, 40 to 59. Yeah. And using the Kadigo categorization, which best assesses this patient's albuminuria. So he's excreting 400 milligrams per gram. So the ratio is 400 milligrams per gram for this particular patient. And our categorization is A1, A2, and A3. So which category does the patient fall in? C. Yeah, you're very right. Abir, Amina, you're very right. Yeah, so this is C. Thank you so much for answering. Yeah, this is A3. Right, so the kidney function assessment, as we all know, the famous Cockcroft and Gault formula, but it is just with experience, the pharmacists who are working in hospital, you would have known how much error prone this particular formula can be, because whenever there is an abrupt variation, there's an acute insult on top of a chronic condition, or if the kidney functions are not normal over a longer period of time, the Cockcroft-Gault is a very inaccurate way of calculating the GFR, but it just comes on handy, and it's just a rule of thumb for calculating the GFR. That's how we calculate it. And just knowing this formula is an important thing that you guys should have. And for the pediatrics, it's an important thing to have the formula with us. Better not try to apply the Cockcroft on the pediatric population. Though how we come across a diabetic nephropathy case in a pediatric is usually in type 1 diabetes, which we usually expect in the children, is usually not associated with diabetic nephropathy. Whenever there is a type 1 diabetes, it's an important thing, since I've not written in the slides here. Any patient who comes with type 1 diabetes, the chances of them having a concomitant kidney injury is very rare, because type 1 is usually diagnosed very early in our lives. So, and kidney function, we all know with the passage of age, they already get compromised. So chances of a patient, say in 40s, being diagnosed with diabetes has a higher chance of showing diabetic nephropathy as compared to a 16 years old who comes with type 1 diabetes, right? So the association of diabetic nephropathy is more with type 2 diabetes as compared to type 1 diabetes, just because of the reason that the type 1 diabetes patients usually are younger as compared to patients who are type 2 diabetes. They're usually older, right? So assuming that the non-pharmacologic approaches have been optimized, which is the best to limit the progression of the kidney disease. We're going to go into the detail of this. Let's not talk about this right now. So there has to be an yearly screening for type 1, 5 years after the diagnosis, and type 2 on diagnosis and yearly. So we need to see the kidney functions very clearly when the patient comes with diabetes, right? And the clinical management is multifactorial. So we talk about the non-pharm, we talk about the pharmacologic management, and it's not only focused on the kidney itself, it's more focused on the heart, more focused on the cholesterol, and then the kidney is relieved of the pressure on its own, right? So lifestyle is the typical DASH diet. We all know the DASH diet, right? We all know the DASH diet. Yes, Osama Hassan, you guys are very right in that question. Thanks for answering. So for the lifestyle, we talk about diets which are rich in good cholesterol, which are low in sodium, low in sugar. So any processed sugar is bad. Anything that's sweet directly is bad. Anything that has a bad cholesterol in it is bad. We prefer the good cholesterol. The good cholesterol being diets which have egg whites, or the fish, salmon, or avocados, or green vegetables, or beans. These are the good cholesterol containing foods. Then we ask the patients to limit the sodium and to avoid the artificial sugars, right? And smoking cessation has such a significant role to play in that. Yeah, LDL. Yeah, so smoking cessation has an important role to play. So always, any patient who comes with diabetes, we check the blood pressure and the kidney functions, and we usually ask them about the smoking status. Here in Pakistan, the chances of anybody being alcoholic are relatively less as compared to in the Western population, because this usually is the staple drink for everyone. So we do ask about alcohol a lot. and we try to investigate and through different questions here. And smoking also is more prevalent here as compared to it would be in Pakistan, but always try to ask such kind of questions as pharmacists when you're talking to patients with diabetes or counseling them. Try to bring these questions later on when you have done the initial discussions and develop the confidence, because that way they are more open about it and they'll like accept, or they'll be ready to tell you based on the confidence levels that you guys have developed. And smoking cessation is very important. The reason I'm talking about the confidence level between the patient and the caregiver is because a lot of patients, if they're addicts or if they're smoking, they have a direct 60% increased risk of death because of MI, post diabetes, and ESRD associated death. So there's a direct temporal relationship between smoking and death in diabetes patients. So we need to bring up this discussion about quitting if they are smoking right now, or assessing their smoking status if the patient is smoking. And obviously weight management, who can ignore this important thing here? Because these metabolic diseases, they're actually very much related to the body weight and the kind of mechanics the body has. So the first line therapy for diabetic kidney disease, whenever a patient comes with type 2 diabetes specifically, and you're looking at the cardiac risk factors, has a cardiac risk factor, or has a kidney risk factor, or has an abnormality in the kidney, you try to add SGLT2, the sodium glucose co-transporter inhibitor, the SGLT2s. These medications are the cornerstones of therapy for reducing and preventing the progression of the kidney disease in a diabetic patient. So always remember, a patient with diabetes comes for therapy, has had an abnormal HbA1c, the diabetes test, and you look at a compromised renal function, always add an SGLT2 in the regimen. It has a documented evidence of preventing the progression of the disease and has a mortality benefit. Then MRAs, the mineralocorticoid receptor antagonists. So they are usually preferable if the potassium levels are normal and the kidney function is also okay. Okay means that the creatinine clearance is above 25 mils per minute. So they can be considered if the patient has tried an ACE inhibitor and an angiotensin receptor blocker earlier, and the maximum doses have been utilized and it's not controlling the blood pressure. So with the diabetes and the kidney disease, we target a strict blood pressure control, and we apply ACE inhibitors or angiotensin receptor blockers into the therapy. If the maximum doses have been ineffective, we can add a mineralocorticoid receptor antagonist, the non-steroidal ones, finerenone or the hexaceluron, right? And then the calcium channel blockers and the antiplatelets based on the ASCVD, right? You can ask any questions in between if it's confusing or anything. So SGLT2s, so the co-transport of the glucose and sodium helps bring the glucose and sodium back into the blood. There's a usual conservation method nature deploys into the kidneys, in the proximal tubules, right? So SGLT2 inhibitors, they actually increase the excretion of glucose and sodium into the urine. So they cause glucosuria. So the glucose actually gets flushed out of the urine. And because of this, the pressure, the glomerular pressure reduces. So they have mechanistic role in preventing the progression of the kidney disease in a diabetic patient. And they control the blood glucose as well because of excreting enhancing volume of glucose out of the body. So that's why they have the mortality benefit, and they have the reason they're here into the market is major because they slow the progression of kidney disease on top of diabetes, right? So they have a huge role now. The first one came into 2014. We're going to talk about the names as well. So this is a very helpful, I'll share the PDFs of both the KDIGO as well as this ADA and Diabetes Canada recommendation. They're very helpful and handy since they're not very heavy. Like they're quick checks, like these tables, they're very easy to understand. So the first row we're talking about is the cardiac event. So a patient comes with diabetes, he has an HbA1c which is not in control and has cardiac risk factor. For example, he's smoking. For example, his blood pressure is not controlled. So you want to add a medication into the primary therapy. The primary therapy for diabetes, type 2 diabetes, is always metformin, right? So now we're going to add another medication if the risk factors are higher or if the HbA1c is not controlled with the primary therapy, right? So a patient is diabetic, and we checked his HbA1c, and he was declared as diabetic, and we started metformin. Now 3 to 6 months down the road, we saw that the HbA1c is worsened. So there's poor glucose control, and then there are cardiac risk factors, or there was a cardiac event, or the blood pressure was not under control. So we need to add a medication. We need to upgrade the therapy, right? So that's what we're talking about. So we'll add a GLP-1 RA analog. The medications specifically are the linagliptins and the sitagliptins and such kind of medications, right? So we add them into the regimen to improve the response to the glucose, blood glucose. Now we talk about the second row, talks about the hospitalization due to heart failure. In that case, we add an SGLT2, the one we discussed about that. And then progression of nephropathy, look at the third row. When you need to slow the progression of the kidney disease, you need to add an SGLT2 into the regimen, right? Yeah. So you need an SGLT2 into the regimen, which is going to help. Similarly, if a patient is more than 60 years old and has 2 or more than 2 cardiac risk factors, always add an SGLT2 inhibitor into the regimen. It has the mortality benefit, right? Because of the mechanism that we discussed earlier, that it increases the excretion of sodium and glucose into the urine. They cause glucosuria, right? And now the ACE inhibitors and the ARBs. Whenever you come across any patient with nephropathy, ACE inhibitor and ARB is a must. Specifically with diabetes, if you have to control hypertension, the drug of first choice is ACE inhibitor at maximum doses. You start at a lower dose and upgrade to the maximum until the blood pressure is under control, because it has the mechanism of reducing the glomerular blood pressure. No other medication has that role. So they're specific for that. They're the drugs of first choice. Always in a diabetic patient, add an ACE inhibitor, no matter what. If the ACE inhibitor is causing cough or problem, switch it to an ARB. Try to play around things, but make sure that the patient ends up receiving an ACE inhibitor or an ARB. Just ये इसको अपने साथ attach कर लें इस चीज़ को. Any patient who is a diabetic, even if you get a glimpse of high blood pressure, just add an ACE inhibitor, because it has the mortality benefit, right? And the reason is because it causes afferent arteriolar vasodilation. So at the level of the arterioles, where the pressure is higher because of high glucose, they actually cause vasodilation. So they reduce the pressure of the blood into the afferent arterioles, the venular pressure, which is bringing the blood back to the heart, is reduced. So they reduce the glomerular blood pressure as well as the cardiac blood pressure. So they have the mechanistic role in that, and because of that, they have the mortality benefit, and they're so well tolerated. Now the SGLT2s, they are different types we have in the market. Just be like aware of the names, because most of them, their patents haven't expired. So we call them with their names. Invokana is the typical canagliflozin, the first one that came in the market. The Forxiga is so commonly used, like almost every other patient with diabetes will have Forxiga in the regimen. Then we have the combinations as well. The metformin combinations, canagliflozin plus metformin, the Invocamet, Zig Duo, and Synjardy. These are the usual doses. I didn't mention the doses here. Mention on the next slide. Yeah, so here. So any patient with a creatinine clearance of 30 and above, 30 and above, SGLT2s can be initiated. Any patient with a creatinine clearance of 30 and above, right? Any patient who has a grade 3 onwards, like grade 1, grade 2, grade 3, can have an SGLT2 added into the regimen. There are no adjustments required. If the patient was already on an SGLT2, it's not in the slide, I'm just speaking out. So if the patient is already on an SGLT2, the kidney functions previously were good, now they've worsened, you can continue canagliflozin or dapagliflozin and empagliflozin until the creatinine clearance is above 20 mils per minute, above 20 mils per minute. So if the patient already is on an SGLT2, continue the therapy until the creatinine clearance drops below 20 mils per minute. But if it's 20 mils per minute or below, remember that these medications work only on the proximal tubule. They're not on the loop, they're not on the distal. They work on the proximal tubule. They're going to be ineffective. So there's no point, right? So that's why you need to make sure about regularly keep checking the GFR for such patients. The HbA1c is very important. Keep on checking that frequently because our therapies are guided by the HbA1c, right? So our therapy actually is guided by the HbA1c. So we do it at the baseline, then we do it twice in a year, usually grade 1 to 3. For grade 4 to grade 5, we need to repeat it more frequently, like every 3 months, right? Now, very important, the blood pressure target. Whenever there's diabetes, we are strict with the blood pressure. We can't afford a loose blood pressure control. We need to be very strict. So the rule of thumb is 130 by 80. Patient should not be more than 130 by 80. It doesn't make sense in a lot of cases. For example, if say a patient 80 years old comes with diabetes and has macroalbuminuria even, I would be scared to target a strict blood pressure for him because that increases the chances of him having a low blood pressure. But still, the guideline says you have to be strict with it. So any patient with mild albuminuria, which is less than 30, target 140 by 90. If it's severe albuminuria, grade 4 onwards, you target 130 by 80. So always be strict in the blood pressure control. That's very important. And whenever you come across high blood pressure with diabetes, the drug of first choice is ACE inhibitor, right? It's the ACE inhibitor, right? So you always try to get that. Okay, so the management of diabetes kidney disease is multifactorial. First of all, you target a good diabetes control, you control the blood pressure, you do protein restriction, you add statins. Whenever necessary, you do the anemia management and you do the vitamin D management. Why we need to manage the anemia? Because erythropoietin is synthesized. PDFs, yeah, I can share. Okay, so the erythropoietin, which produces like is a precursor for the red blood cells, it is produced in the kidney. So in chronic kidney disease, there is erythropoietin deficiency. So there is anemia. Then there is reduced iron absorption through the food because there is already cachexia. Patients are usually anorexic, and then there is nausea. So the oral absorption of iron is reduced. So there's a dual way of causing anemia. Then there's vitamin D because kidneys actually convert the D2 to D3, which is the active version of vitamin D. So there's no activation. There is reduced activation of vitamin D in end-stage renal disease. So because of that, there's vitamin D deficiency, right? So we talk about diabetes control and blood pressure control and protein restriction to avoid albuminuria, and adding statins to control the cholesterol, and anemia and vitamin D management. So the first lines, as we discussed earlier, I'm talking about this again and again, the ACE inhibitors and ARBs are the first line of choice. The important thing is that when you start an ACE and an ARB, there is going to be an increase in the serum creatinine. There would be some immediate reduction in the GFR right after starting the ACE and ARBs. This usually happens, but this should not stop us from prescribing them unless the increase in the serum creatinine is less than 30%. Unless the increase in the serum creatinine is more than 30%, do not stop an ACE inhibitor or an ARB. Never stop it unless the increase in the serum creatinine is more than 30%. Or if the serum potassium is more than 5.6, we need to stop it. Unless it's more than 5.6, do not stop it, right? Always try to give ACE and ARB as much as possible. Then for the stage 1 to 3, add-ons can be a thiazide diuretic or a loop diuretic. The second lines are always the calcium channel blockers, and in amongst the calcium channel blockers, we're specifically talking about the L-type calcium channel blockers, because the L-types are usually on the kidney arterioles as well. So we're talking about amlodipine, nifedipine, medications like that. So the non-dihydropyridine type calcium channel blockers, right? The targets, very important. HbA1c, 7%. Always. Target 7%. Anything more than 7% is a risk. Dietary sodium, not more than 2.4 grams per day, which becomes a teaspoon. Not more than a teaspoon of salt in a day. And protein restriction, not more than 0.8 grams. So try not to have chicken or meat every day. That's what we can get out of this. Now, this is a very important. So this is a very important slide with respect to what the guidelines ask us to follow with respect to the practice. Right now, the another recommendation as the preventive measure, any patient with diabetes, even if the patient does not have a high blood pressure, even if the patient does not have a high blood pressure, but has a risk factor for cardiac disease, has a risk factor for cardiac disease. For example, the patient has high cholesterol, but not high blood pressure. For example, the patient smokes, but does not have high blood pressure, and the patient is more than 55 years of age. So a patient who has diabetes and who is more than 55 years of age and has at least one cardiac risk factor, you start an ACE or an ARB right away, even if the blood pressure is normal. So any patient with diabetes, more than 55, start an ACE inhibitor or an ARB, right? Now for the statins, important. For the statin therapy, atorvastatin, rosuvastatin, medications like that. For the statin therapy, any patient with diabetes and more than 40 years of age, any patient with diabetes, more than 40 years of age, add a statin into the therapy, right? It has mortality benefit. So any patient with diabetes more than 55, add an ACE and an ARB. A patient with diabetes more than 40 years of age, add a statin as a general rule of thumb. You can go into the details on this document here on the slide. And we discussed about the mechanism of ACE and ARB. So yeah, enalapril is okay. So now talking about the mineralocorticoid receptor antagonist therapy. So type 2 diabetes, patient has exhausted the maximum doses of an ACE inhibitor or an ARB, but still they could not control the blood pressure. You add a mineralocorticoid receptor antagonist like finerenone. So yeah, I misspelled it here. It's not finerenone, it's finerenone, right? So this is the drug of first choice. It's a non-steroidal mineralocorticoid receptor antagonist. The steroidal ones are like the palirenone and the spironolactone. They are for the heart failure. They're not for the kidney specifically. So if the patient has diabetes, you have exhausted the maximum doses of ACE or an ARB, the blood pressure is not under control, and the patient also has a compromised renal function, you add finerenone into the therapy regimen, right? Unless the potassium level is unstable, unless the GFR is less than 25 mils per minute. So any patient with a stable potassium level, which is not varying, any patient with a GFR more than 25, and then they could not control their blood pressure on an ACE inhibitor or an ARB, you add a mineralocorticoid receptor antagonist, right? I hope that I'm not confusing everyone. Okay, right. So these are actually the guidelines we play around with the with how to manage the patients. So very important from practice point of view. Okay. Okay, so statins, we know that we continue even in dialysis, but we never start in dialysis. So always give them. They're usually excluded through the liver. So not much of a problem adjusting them in renal dysfunction. But if the patient is not already on a statin and the dialysis has started, you do not just start them. But if the patient is already on a statin and the dialysis starts, you continue using it. So continue them as long as possible, right? And they are the HMG-CoA reductase inhibitors, which inhibit the production of the cholesterol, right? Now coming to anemia, which is very important. So you look at the hemoglobin. Any hemoglobin, the target is more than 12 for females and more than 13 for males. You do the retic count, iron binding capacity, and ferritin. If there is iron deficiency, you do oral or parenteral iron replacement in the patient. If the anemia is corrected, you do the maintenance. But if the anemia is not corrected, you check the hemoglobin again. If the hemoglobin is less than 10, if the hemoglobin is less than 10, you start erythropoietin therapy, which is a poietin alpha, darbepoetin, medications like that. So they do not start unless the hemoglobin is less than 10, right? These are the different types and the doses. So the iron therapy usually is not recommended. Specifically, the oral iron therapy is not usually recommended because of the poor oral absorption. There is severe nausea, anorexia. They're usually not recommended. And this is the formula for parenteral calculation of the iron. Such kind of things, it's very interesting if we can do the calculations, but I've just realized with experience that in online sessions, the worst idea to do is to ask to do the calculations because it's very erratic. Usually when it's an in-person discussion, it's more fun rather than doing it online. So you guys can practice on your own. These are handy formula for practice as pharmacists and hospitals specifically, or for any patient you come across in community. For vitamin D, as we discussed earlier, so the kidneys are activating vitamin D into the active version to be utilized. When there is a renal disease, there is reduced activation. So any patient with a level less than 5 has a severe deficiency. Any patient with 5 to 15 is mild, and 16 to 30 is insufficiency, right? Now we're talking about the renal replacement therapy, if we are clear so far and if you're not running out of time, right? Yeah. So renal replacement therapy is like the last, amongst the last options for patients with end-stage renal disease following diabetes, right? And when we do there are multiple reasons for which there can be. The most common way of doing the renal replacement therapy is through the AV, atriovenous fistula, which is natural. So there is no external catheter inserted, lesser chances of resistance and everything. Then is the AV graft, and last is the catheters because they have higher chances of infection. And the complications we all know can be hypotension. And the way to manage is this Trendelenburg position, or you can do mitre drain or saline boluses. I'm skipping the questions because, and the last resort is a kidney transplant. So the patients who have just exhausted all other options and they're functionally anuric, they have a high survival rate with transplant if that can be managed. So the 5-year survival rate is 60% in type 2 diabetes mellitus with kidney transplant as compared to 2% in renal replacement therapy. So, you usually come across this verdict from a lot of patients that the hospital pharmacists, they would have come across this notion that if somebody goes on a dialysis, they never get off. और आपने patients को सुना होगा ये कहते हुए, they usually get scared after dialysis. We usually promote against that. We do not believe that RRT is the final step and after that there's no coming back. But if you look at the evidence, it actually is so. We can only slow the progression, but the usual mortality rate is very high within 5 years. It's 2% survival rate in 5 years. And if you're able to do a kidney transplant, it has a 60%. It has even a 98% survival within the first 2 years. It's even higher in the first 2 years. So this is all from my side about the, all from my side about the diabetes nephropathy. The key things here, I've just added as a Pearl quiz for all of us so that we can remember the key points here. So if you guys can comment into the chat section about the Pearl quiz questions, so we'll be able to see if we have like gotten and memorized things well. So SGLT2 inhibitors like the canagliflozin, empagliflozin, dapagliflozin, they're contraindicated in diabetes patients with GFR less than 30 mils per minute. Is it true or false? Great, Junaid. Yeah, thank you. So any other answers, please? True, yeah, Afifa, you're right. Aruj, you're right. Yeah, it's true. So they're contraindicated if the GFR is less than 30, but if the patient is already on an SGLT2 and then the kidney function drops, you can wait till 20. Try to give them as long as possible, right? Now, coming to the second one, yeah, Huawei Y9 Prime, whoever you are, you're right as well, Usama. Amna, yeah, they'll share with you definitely. Okay, so the second is any diabetes patient more than 55 years of age, ACE inhibitor and ARB therapy is recommended. True or false? Zareen, you're right. Isma, you're right. Afifa, you're right. Nadia, Sabah, Kiran, Refat, great. Thank you so much for answering. I'm so happy that you guys are picking the right options. It means that you'll be able to manage your patient so well. That's so good. Right. So yeah, this is true. Yeah, all of us are true. All of us are right. Usama, Laiba, thank you. Yeah, thank you. Okay, so question number 3, any diabetic patient 35 years old and more, statin therapy is recommended. True or false? Shazib, great. Sabah, great. Aruj, Maria, Kafia, Huawei Y9 Prime, whoever you are, you're right. Arshi, Zareen, Amna, Faika. Faika, hi, how are you? Great. Yeah, Afifa, yeah, you guys are right. Okay, that's great. Yeah, so the limit is 40. So any patient with diabetes 40 and above, recommend adding a statin regimen therapy in the regimen, right? So this is false. Now, question number 4. For 38 years old, type 1 diabetes mellitus. This is a type 1 diabetes mellitus. I missed explaining this to you guys, so it's good that I added that, so I'll explain it now. So for a 38 years old type 1 diabetes mellitus patient diagnosed 15 years ago, statin therapy is recommended. True or false? Just want to see if Sabah, you're right. Yeah, so I missed discussing this with you guys. So if the patient has a pre-diagnosed diabetes, this would usually be a type 1 diabetes patient. And the time period for which they have had diabetes is 15 years or more than 15 years to just add a statin into the regimen. So it's either a diabetes and 40 years and plus, or either it's even less than 40, if the patient is even less than 40, but he has had diabetes for 15 years or more. This would be usually a type 1 diabetes patient, right? So because he'll be less than 40, and they'll have diabetes for a long period of time, like 15 years or more, you add a statin into the therapy, right? Am I clear? Yeah, you guys are right. Suleiman and Abdul Alim. Yeah, very right. Okay, and the last one is, so this is a type 2 diabetes mellitus patient and has CKD. So he has diabetes and he has CKD. And his GFR is 30 mils per minute, right? And his serum potassium is 5.1. blood pressure is 155/90. Is it controlled or is it not controlled? Our target is type 2 diabetes. Our target is 130/80. Blood pressure is not controlled. On average, this is the average blood pressure, 155/90, and on maximum dose of irbesartan. So he's exhausted the maximum dose of irbesartan. Finerenone is a good therapeutic option or not? So we talked about, this is an important question regarding MRA. Not, Rifat, you're very right. I am so happy and so proud of you guys. You guys picked that up so well. Thank you, Faisal, Umair, Sawa. That's great. Honestly, Sumaya, that's great. Yeah, you guys are right. So we talked like in a hurry about the contraindications to finerenone. So one is that if the patient has an unstable potassium level or the level is above 5. So any potassium level above 5, never use MRA, or the patient has a creatinine clearance of 25 or less. So this patient has, though, a GFR of 30. So he's above 25, but his potassium level is 5.1. So we cannot choose a finerenone. We'll have to go to another medication for controlling the blood pressure. The most common being a calcium channel blocker, maybe, right? As an alternate to the ACE and ARB. Yeah, false. Suleiman, you're right. Afifa, you're right. Thank you so much, guys, for participating so well. I am honored to be part of this session today. A special thank you again to Sir Aslam Siddiqui and Dr. Uzair. This is all from my side. Thank you.
Thank you so much, ma'am. Jazakallah. Thank you so much, Dr. Umme Javeria and Dr. Sidrah Andleeb for the great presentations. And just to remind, our next webinar is on Saturday, 29th April. The topic would be safety and wellness at workplace. So stay tuned. We will be looking forward for you people. Again, that's a great presentation, ma'am. We have learned literally a lot. So we'll end the presentation. We'll end the session here. Thank you so much for joining.